Welcome to PodTox. We are on episode 15, and today we've got Dr. David Alfery in here. So we are going to learn we're going to learn about his life, his book. We're going to learn about his kind of position on some medical issues that are going on right now. And it's going to be a great time. So we'll start off with the very first thing. What got you into medicine? We just want to get through the basics.
So what got me into medicine? I was a senior in high school, and the Medical College of Wisconsin was called Marquette at the time. I had an open house, and I went down there, and you got to tour it, and it just really grabbed me. It was so fascinating. They had a cadaver that was covered, and then they uncovered the arm, and it was all dissected, and I was so blown away by that. And I had one of these sort of old country doctors as I grew up that would come to the house. And I just looked at him, what a gentle, wonderful man he was, and in this fascinating science, and said, I guess maybe I'll do medicine. Now, I then went to college, and I sort of, got off the rails, and I almost flunked out, and I had some wild times, and then I went back to pre-med after I graduated, and then finally got into medical school. I had a rough road.
What was your second option if it wouldn't have worked out?
I didn't have one. And Vince Gill in Nashville, he came to town, and I saw him in a little bar in a band that nobody knew who he was. And he did that for a number of years. And then when he was asked, when he finally made it as a star, they said, what was your plan B? And he said, don't have a plan B. Stick with what you want to do and don't give up. And that was sort of my plan B. I wasn't going to give up.
I feel like that's the thing with a lot of people who have something that they have that full drive on. If there's no backup, they have to do it no matter what. So with your book, first off, what was the inspiration for writing it and deciding you were going to go through with all that?
Before I answer that, let me just thank you for having me on and for having read the book. It's really an honor when somebody reads my book, and I love it when they connect on a real deep basis. I finished my career, and I had all these incredible things happen, like most physicians, and I just decided that I would write about them and kind of tell my wife and three daughters where I had gone for 36 years. And as I started to write it, I looked at other things that are written by physicians, and I realized nobody had ever written a book about the OR from the perspective of the anesthesiologist. And I mean, there's tons of, Dr. OR books, but none from anesthesia, which is kind of mind-blowing because, it was discovered in 1847 and is considered by many to be the biggest advance in medicine in the history of ever. So it sort of morphed from, let me tell you about my life, to let me tell you about what really goes on in the OR. And as I did it, I found out that I was writing far more about the patients than I was about myself, which is a good thing because, who wants to hear about, this retired doc? It's much more interesting to hear about patients. And so it really then became a book where I think I'm kind of almost a bystander. I mean all the chapters, but it's really focused on the patients. And so it ended up being a book that'll tell you about what life in the OR is like and what really goes on there. But what is it that we can learn from these interactions with patients? And that's why the subtitle is What Patients Teach Their Doctors About Life, Death, and the Balance in Between.
And I thought it was super interesting hearing kind of your viewpoint of a lot of the patients and their families. Like that was the big thing. It's something that I have a hard time grasping whenever it comes to my kids. Whenever you had your child, did it hurt more whenever a child passed on the table?
Well, thank God that was so rare.
Sure.
But once I had children, it it was every time I took care of a child, and I didn't take care of a lot of kids. I really took care of them on the medical missions that I went on. Then we had kids, but I really had an adult practice. But it was much more personal once I had my own children. And I think that's, I mean, that's just part of life. My wife, as you know, is a chronic pain patient, and I appreciated chronic pain patients, but I didn't really appreciate them until my wife became one.
With your book, the part that touched me was definitely the child in the beginning of the book that had, the heart issue, the congenital heart issue. And I have to say, that's what really taught you dignity, right? Like how to be, is that what taught you dignity as a physician? Because at school you don't learn these things, correct?
Yeah, when I was in medical school, we weren't taught anything about how to be, how to interact with patients, how to interact with their families. I think they just sort of expected you to pick it up along the way. And if you were fortunate to have some good mentors the way I did, then, you hopefully didn't make as many mistakes as other people did. But it was definitely a learning process. And it was experiences like the loss of that little girl. And forgive me, some of these, even though I've talked about this book and, read these excerpts or read these chapters so many times, when I talk about them, I sometimes still get emotional. Just the whole experience of seeing that cardiac surgeon so careful, sewing up her chest, putting the bandage on, as if he was going to deliver a live girl back to the parents. And just the dignity that he and the respect that he showed to the child. That's the kind of thing that just gets seared into your brain.
Right.
And you realize, aha, big lesson here. And so that was one of the many lessons that my patients and the interactions taught me.
That's amazing. It really touched my heart, that one in particular.
Well, and let me tell you something really interesting. I gave a talk to some chairmen of anesthesia departments, and I thought, gosh, what do I tell these people? These are at the height of their careers and everything, and what are they going to learn out of my book? But I told them that story, and I said, you all are mentors. And to the people who haven't read the book, I'll just say that it was a powerful episode in the operating room. And I didn't realize it at the time but the physician who I witnessed with this little baby that died on the table, I didn't realize it at the time, but he was a mentor. And so I told these chairmen, you all are mentors, but you've had mentors. And think of the mentors you've had. Did you ever really, at the time, or have you since, told them what they've meant to you, how they helped shape you?
Right.
And if you're like me, there's lots of people you've never told. And when I finished the book, I chased down that cardiac surgeon, and we hadn't talked in over 40 years. And I called him and I told him, Ken, I'm 40 some years too late at telling you how profoundly you affected me and my practice. And I said, I'm going to send you the book because I want your family to read that chapter.
Wow.
Really, for your wife, your kids, your grandkids, to understand something about you that they've never known.
That was a beautiful gift. I have to say, that was so thoughtful of you, because that chapter really, really just, it sits on my heart. And I loved hearing the book. I know that you sent me the book, but I loved hearing the audio version of the book. Guys, if you're going to go buy this book, hear the audio version. It's narrated by Doc. It's amazing. It's going to pull at your heartstrings, trust me, and it makes you realize how short life really is.
And talking about the mentors, I just say to anybody listening, just think about your life. Have you had some mentors that have really profoundly affected you? And if you haven't told them, it's a really good idea to do that. It's never too late. And after 40 years, it wasn't too late for me. And then about Dr. Carter in the book.
Yes.
I found Dr. Carter as well.
Wow.
We've reconnected.
That's amazing. Honestly, Doc, I feel like you can make this book into a movie.
Well,
I'm
I
serious.
gotta find someone that wants it. It was just impossible to get it published. My agent, my literary agent, it was a miracle that I got one. She's very well known. She'd send me the rejection letters from the major publishers.
Wow.
And they all basically said, hey, Carolyn, so good to hear from you. How's Bill? We read Dr. Alfery's manuscript over the weekend. Oh my goodness, where did he learn to write? Unfortunately, though, without a social following, we have to pass.
Wow.
And it's just impossible without social media. Or it's almost impossible. It was impossible for me to get something published. So I've got this obscure little publisher that we found. And that's why actually I got on social media.
I wanted to ask you that question. As a physician, some of the things that you talk about, some doctors don't like putting everything out there on social media. They're very private in their life. Was that hard for you?
No, it wasn't. After I wrote the book, it wasn't hard at all. But the amazing thing is that, the book came out and a few months before it, I'd been told by so many people, you got to get on social media because that's the only way that people are going to learn about this. So I got on Instagram, and then someone taught me to do that. She said, well, let's get you on TikTok. And then to my surprise, my TikTok thing sort of took off.
I love your videos, Doc. They are amazing, seriously. I love the little series that you do. They're very educational and on point.
The amazing thing to me was, I thought, well, all right, I'll get some followers and then I'll be able to say, hey, I wrote this book. But I was amazed, first of all, I got a bunch of followers, but more than that the things that I was talking about seemed to really resonate with a lot of people.
Right.
I'd be getting these comments that just blew me away, like when I did illicit fentanyl. And if I trip up and just say fentanyl here, just realize that I've talked about fentanyl for 40 years because I use it. I don't always say illicit fentanyl the way I'm supposed to. But I did some reels on illicit fentanyl, and then I'd get comments from women that would be, or men that would say, my son Patrick died the date. And oh gosh, I did a little series on meth, and I'd get a comment, your voice is so soothing. You've really helped me stay off of meth. And so I was really blown away that I started something to advertise my book, but it's really been rewarding for me, thinking that, well, maybe I've made a little difference in a few lives here.
You have. You absolutely have, Doc.
Yeah, 100%. And I think one thing that you could maybe do, share little tidbits that aren't in the book, little stories that you think are interesting, because you have, regardless what the publishers say, you had a really great way of telling the story. So, yeah.
And I saw that you narrated like little excerpts, like if you didn't buy the book, you should share those little tidbits on your TikTok, because I thought the same thing, Kyle. That will bring people to your page because that book is amazing.
Well, thank you. Thank you. I don't know. Well, I had a couple of editors that helped me. I was an English major in college, so I knew how to write, and I've done a lot of medical writing, chapters and articles and all that kind of stuff. But it is just so technical and kind of boring.
What's the process of that? Do you have to be asked to be in a medical journal, or is it something that you try to submit for?
Yeah, you submit it for peer review.
Okay.
But it's the most amazing thing. That I decided when I was a resident. You'd read articles by doctors, and you'd say, and then some of them would be, they'd be kind of puffed up because, thank you, they'd be puffed up because they had written a medical article, and I thought, well, I should try that, and then that just led to more writing, and then the most amazing thing happened, at least amazing to me. There had never been a a big multi-authored textbook of anesthesia in America. And the year I did my fellowship, my extra year of training, cardiothoracic, the fellow that was working with me, my supervisor, was asked to do 2 of the chapters in that big Bible of anesthesia. It was
Wow.
so I was his fellow. He said, well, David, we'll do this chapter together. So when it came out, and by the way, I think I might have it behind me.
That's amazing. What an achievement and an accomplishment in a career.
That's this big.
Wow.
It's 2 volumes. But the amazing thing is, it came out, and there were stamped on the cover were 25 famous names and mine. So it was just so serendipitous, these things that happen in your career. So I did a bunch of writing, but it was so different from this. And I just, as I wrote it, the book, I just tried to be as honest as I could.
I could tell that it was very sincere, and especially the parts where it talked about like the little gypsy boy, and you go in on your missions. That was
Yeah, these medical missions, it's interesting. I'll tell you two observations. We got back from one, and I had one of my partners said, David, you had a week off. That's the last thing I do when I had a week of vacation. Now, this is a really nice guy, but he was seeing the psychiatrist twice a week. His life was kind of a mess. And I thought, Bob, I got news for you. That's what you need to do on your vacation. And people would say to me, oh, you're such a good guy to go on this mission. But they didn't realize that you get so much more back than you ever give. And that's why medical people and lay people that go on medical missions, they generally don't go on one. They go on a bunch.
What made you switch from doing surgery to going to be an anesthesiologist? Because it seemed like, especially when you talked about holding that first heart, like that was such a big moment for you.
Yeah.
And then it kind of changed.
I trained back when they didn't have limitations on training hours. And so I remember one week I worked over 100 hours as an intern. It was just insane. And we had one of the interns didn't show up my year. So what was supposed to be every third night call, a couple of them were every other night call, where you'd get up in the morning, you'd be at the hospital at 5:30, and you wouldn't go home until 8 o'clock the next night. And that night that you were on call, you never went to bed. And if you did that for 15 times, you're just absolutely toast. And I thought, you know what, I don't think I can do this. And the chief of anesthesia, I was doing the ICU rotation, pulled me aside and said, David, I heard you're going to leave surgery. I said, I'm thinking about it. He said, come see me. So I saw him in his office, and we talked about anesthesia, and he said, man, this is really a good profession. You're the ICU doctor of the operating room. And I went and thought about it a while and came back a week later, and I said, you know what, I think I'll give that anesthesia a try. And this, as you know, this is in the book. And he said, well, I know the chairman, and he named all these places. And I thought, well, San Diego ought to be pretty good weather. How's that? And he said, oh, it's a top 5 program, but they'll be filled. But they had somebody drop out, and so at the last minute, they put me in. So, one of the most monumental life decisions that I ever made was based on this conversation with the chief of anesthesia and thinking, well, the weather would be pretty good in San Diego.
Was that conversation as important as the one you had with your wife? Because she was not about it.
Yeah, when I was so blindsided by her, and it just shows that, you get wrapped up in your own life and you're not thinking about what your girlfriend is going through. And I'll always remember I was outside the VA hospital on call, and she came to see me. I had had dinner or something. I remember it was dark, and we talked, and I said, hey, well, I got great news. We're going to San Diego. And then she literally said, you're going to San Diego.
Right. I would have said the same thing.
Yeah, she said, I moved for you once. I'm not moving for you twice.
How was that family life? Just, I mean, working so much. Obviously, by the time, you did have a child and stuff like that, you were a little bit more slowed down with the anesthesia and all that, but that's a lot of juggling.
My job in Nashville was crazy. We were always behind. We never had enough people. And so I ended up working far harder than I ever wanted to for,
Right.
Almost all of my career. And I missed so much of the kids growing up. So that was tough on me and tough on them. But the amazing thing is they're adults and they've got their own children, and they look back and say, Dad did so much with us. Oh, Dad, yeah, he took us on daddy trips, just Dad and me to New Orleans. Well, and they remember that as a bunch of trips, but I only took one. So you really try to focus on your kids as much as you can, and hopefully they remember it as a wonderful childhood. And my dad was always there for me, even though he missed some of those plays and some of that other stuff.
I worry about that with my kids because I'm extremely busy. I'm usually pushing like 80, 85 hours a week.
Yeah.
So I don't know. I try and make all the time count.
And I think that's the key. Make the time count.
Absolutely.
The next part of the book I wanted to talk about was something that I guess I see with some doctors where it's like you don't know if you're making the right choice, and it's when you were going to put that epidural in that lady's spine. Obviously you hadn't done it before and she was comfortable with it, but where do you find that balance of like, I really should do this or I shouldn't? I know you were stressed about it, but
it's really tough. And the thing is, you have that your entire practice life.
Right.
There are new things. When are you ready to do it on your own? When are you ready to teach someone? And that's just a judgment thing. I think that I don't know how to answer that question other than you feel like you can do it safely, and you're honest with the patient. And I tell you this, as I was putting that in, I didn't get it the first pass. And if I hadn't got it the second pass, if I hadn't felt that I was there, I think I would have said, I just don't think I'm the guy to do this today.
With chronic pain, did your wife always have chronic pain, or did she have it as she,
So I got my sort of subspecialty training in cardiothoracic, but I also had my pain boards and did a lot of procedures early in my practice, and then just sort of gave that up. Our pain clinic closed, and when it reopened, I just stayed in the OR. I always cared for pain patients, and I appreciated what their problems that they faced, but I never really appreciated them until my wife became a chronic pain patient.
And how was that on like your relationship and stuff like that? Was that difficult to navigate? Did you send her to one of your colleagues? Like, I know the best of the best that can take care of you.
This is one of the things I wanted to say on this podcast. I don't know how patients navigate the healthcare system if they don't have an insider.
Right.
It's almost impossible. It's so convoluted. It's so many hoops to jump through. And now if you're a pain patient, it's even harder because there's the whole, how do I find in this environment, how do I find a competent, caring, compassionate physician that's willing to stand up to the CDC guidelines and say, look, I'm going to prescribe what you need. So it's really, really tough for them. I just found someone that I knew was very, very good and said, Peter, I'd like you to take care of my wife. And that was good. And then Peter left practice and they found another guy. And but here's an example of how hard it was, even for her. She has a bad SI joint, and she gets radio frequency denervation, RFAs of those. Now, it turns out that there's the probe that you get to do an RFA in the neck or the lumbar area doesn't work very well for the SI joint. And she got RFA'd, and she didn't get much of a response. But I knew enough that there's something called a cooled RF probe. And it's a special probe that you should use for the SI joint. So I went to her pain doc, and he said, I said, did you use a cooled RF probe? He said, no, we don't have it. And I said, I think I should find someone with a cooled RF probe, don't you? He said, yeah, it'd be a good idea. Like you're on your own. Well, fortunately, I know enough people that I knew a pain doc in New Orleans, and I called him, and he said, oh, yeah, we've got that. We've got it at Ochsner. So he set me up with one of the Ochsner docs. So I took her down to New Orleans to get her cooled RF probe, RFA of the SI joint. She got total pain relief.
Wow.
And I'm able to navigate that because I've got access to people, and I could afford to do it. But what if she just been the garden variety patient?
Do you think it comes to privilege a lot of times in the medical care world, honestly?
Yeah, there is certainly privilege. Absolutely. When you're asked to take care of a colleague or the colleague's spouse, it's a big honor. And you don't change what you do, but you might give a little more what we call white glove treatment. You're going to spend a few extra minutes and that type of thing. There's no doubt that she has gotten really attentive care and follow-up and so forth just because she's my wife. But on the other hand, that only extended so far. I had to figure out, first, I had to know, first of all, that there's a cooled RF probe, and then go investigate where they had it, and then, arrange to take her down there to get it.
I always tell people to do your research. Yeah. If you have a diagnosis, you need to do research yourself. You're not going to hear it in a 5-minute doctor's office visit where the doctor's like running out the door with your chart in his hand already. Like, you need to sit there and actually do your own research for things.
How do you feel about like the experimental stuff? And you talked about this in your book a little bit. What do you do whenever there isn't like that solve for a problem? You can't figure out what to do, and you have to go with something that's never been done before. I see a lot of doctors now that don't actually care the same way that you do. So it's a little bit different. They just experiment and they throw it out there and hope it works, and it's like whatever. You would actually study it. I don't know, that's a bad way to put it, but you know what I mean.
Well, yeah, don't get me started on today's doctors. Now, I know there's plenty of kids getting out that are good, but it's a new day in medicine. And I think that part of it is the newer generation that is much more focused on lifestyle than their practice, and I think that shift to caring about your lifestyle has been important, and it should have happened in my generation. But with that is this corporatization of medicine, where if you're an anesthesia, if you're a cardiac surgeon, you almost certainly are working for a hospital or a healthcare system. If you're a cardiologist, you don't have an independent practice. Your practice is owned by the hospital. And everybody's sort of working for the man. And with that is this time pressure. You got to crank the cases out.
Probably a lot of red tape, right?
Yeah, it's a mess. It's a mess. The electronic record has separated patients from their physicians. There's nothing I hated more than the electronic record that I had to use at the end of my career.
Sure.
Now I'm just checking boxes. It just kind of takes you away from the patient. You know, hopefully you've got a doctor that will research what they need to and make the appropriate recommendation. One of the difficulties, and especially with pain, is that there's very little that's black and white. There's so much that is gray zone. Is this procedure, here's a gray zone, epidural steroids. Now, I know Claudia, everybody knows Claudia. I love Claudia. But we disagree on some things. And she said, that's okay, we can disagree. But epidural steroids would be one where I think they're really indicated if you've got an extruded disc and you've got this acute sciatica pain, and you may go to the OR with that. Well, if I can cool that off with an epidural steroid, I may save you from having a surgery. And I've done that with many, many patients. And that's a pretty straightforward call on my part. But if you've got, just chronic low back pain and you get sent for an epidural steroid, well, the chance of that helping you is minuscule.
Right. I've been through all of those before, and it's no fun.
Yeah, and so but in between those two is a big gray zone. What do you do? What shouldn't you do? And I think there you just have to be honest with the patient. I know
Right.
When I would do an epidural, typically we would do a series of 3. Well, where's the science between 3? There's no science. It's just traditionally people have done 3. But I always have a discussion with the patient. All right, we've done 1. Does it make sense to do a second? And if they've done the second, does it make sense to do the third? Maybe your pain's all gone. Well, we're certainly not going to do a third. You just have to be honest with patients and involve them in the discussion and tell them what the pros and cons are, and then what you might do for your family member.
Now, if that patient has underlying substance use disorder, what's the difference there? Because I've been there, I'm a chronic pain patient, but I have both sides of the fence.
Well, yeah.
It's hard.
Yeah, it's real hard. It's real hard. And I don't feel qualified even to answer that question. I know that Dr. EMZ was just on, and
she's amazing.
I absolutely love her. I mean, I look at her and say, okay, my specialty is in good hands.
There you go.
Specialty of
that's a good way to phrase that. I love that.
What do you feel about whenever it comes to things like Sublocade, and because that's kind of got that same gray area now, Brixadi and stuff is coming out, so there are going to be more options where that gets a little bit grayer. Some doctors are very for experimenting and doing a smaller dose if somebody comes in and they're on a smaller dose of bupe or something, but then other doctors are giving 300 milligrams of the stuff when somebody was on 2 milligrams of bupe, and it's just throwing them all out of whack. How do you work around that balance?
Well, I mean, I'm so far from an expert on this. What I know about this is only from reading, and it's just my own philosophy on treating patients, and that is what works for you. And if there's a dose or a method that works for you, if it's a little unconventional, well, you're the one with the problem. So I've got to find a way to help you solve that problem. And more than that, I don't think I can really say. Our experience with folks that were, say, on Suboxone or something coming from surgery is they would get off it for a day or two, and then they'd have their surgery, and we always gave them whatever pain medicine they needed and then try to get them back on their Suboxone.
And that's something that's always a big topic, is when people have surgery and they are on medications like that. It's so a couple of doctors have said that you don't have to come off of it anymore, and I guess that's just because you can push it off the receptors and it's not that big of a deal. Is that something you ended up messing with a lot, or not much?
No, we never did. The patients were usually taken off in my day and time.
It's different though now. It is different. I've had a few surgeries and they told me to continue.
Yeah, and that makes sense. Because we can push whatever dose we want, and
Right. You're
believe
in
me,
control. You
we'll
have the
win.
patient's life right there. Like, how does that feel as a physician to know that you're bringing someone so close to almost death, but you're right on that line?
You know, putting a patient under anesthesia is an absolute rush. I never lost the joy of here's the drug going in and saying, okay, going to be lights out now, or whatever I might say. And, they'd be talking and right in the middle of and they're gone. And there was just something about it that you'd go, they were just awake and now they're unconscious.
It's fascinating.
Um, yeah, anesthesia is a great, great specialty. I mean, it was fun, but it was, as I say in Saving Grace, there was always this little sort of undercurrent of anxiety because when things go wrong, they go wrong really quickly, and
Right.
they can go wrong in a real bad way. When I went into anesthesia, they were some of the highest malpractice premiums in America because of anesthetic catastrophes. Now the premiums are down, they're pretty low because the monitoring is so sophisticated that you really stay on top of things.
So, when you were on your mission, one of the things that you did discuss in the book was in Romania how the hospitals had no equipment. Like you were literally doing things without equipment. And then you felt privileged when you came back here because look at the equipment.
Yeah, in Romania, OpSmile normally did cleft lips and palates, but for some reason we were orthopedists. And, they'd have an x-ray and you'd put it up on the window because there's no x-ray box.
Wow.
Our equipment that we were supposed to use one time, we would use it over and over again. And that's just what you had to do. And between a case, I'd walk out to the sink to wash it, and now there's no water that's running. And they'd say, "No, get the water on for over there," And it was just, that the gypsy boy was called to the ER to see and to walk into an emergency room, and there's no monitor. There's literally no nothing.
Wow.
To try to put his head in a cervical collar and they hand you a cardboard box. You see that and you get back to America and you say, man, I have everything. And it's wonderful when you're practicing medicine to have everything. You don't want to say, oh, too bad, too bad we don't have a cooled RF probe. I know in my practice, we always had a great relationship with our hospital administrator that if we wanted a piece of equipment, we got it. They knew that there was no BS about us. I know it costs $10,000, but we need that.
Now, that's what made you feel so much more gratitude for when you got a call in the middle of the night, right?
Yeah, no matter how sick the patient is, you at least want to feel like you're flying a 747 and not a crop duster. You want to have all the best equipment at your fingertips.
Was there anything that could actually be done in some of those countries like Romania? Because obviously you can't supply everyone with all the equipment, it's not possible. But were there little things that like the organization was trying to do to fix some of that?
There wasn't anything that they could do on that level. This was not many years after the Iron Curtain came down. And it was just a matter of, we're going to bring everything we need on this trip. Now, when we're done, if there was things that we could leave behind, we left it behind. But it was pretty much, pack up the field hospital and move it to Romania for a week. Now, nicely, Romania and so many of these other countries have, with the Iron Curtain down, they have become westernized in their medicine, and things are far, far better.
Now, with fentanyl shortages right now in the operating rooms, how do you feel, like, what do you feel is going to be the repercussions of the shortage?
Yeah, Dr. EMZ and I did a little comment back and forth last night on this, and
Yeah,
I said, hey, this is just the latest, and she said, really? And it's just a reflection that she's young, and she hasn't been
I
around.
read that. I
Yeah,
read
the
that.
shortage that the dinosaurs have had the shortages. The drug that we use to put everybody to sleep, propofol, in 2009, we basically ran out of it in America. There were three manufacturers, and two of them had contaminated samples, and they shut down their factories for one of them permanently. And it was a national emergency in terms of anesthesia and how we got through that. So the fentanyl shortage is unfortunately just the latest of shortages that we've had year after year after year. A lot of chemotherapy agents have been in short supply for years. When COVID hit, because so much of this came from China, or the precursors came from China, that this has been a national problem. It just happened to hit fentanyl now.
I'm sure there are plenty of other options whenever it comes to some of that stuff. I mean, obviously, fent isn't the only thing out there to help someone's pain, but what makes that different than everything else?
The fentanyl's a drug that when I went into anesthesia, I never heard the name, and my first day of my residency, I heard the name because it's used continuously in the OR and has been since the 1960s, I guess. And then no American had heard about fentanyl till 10 or 15 years ago. And if they did, it was because of a Duragesic patch.
Right.
And now everybody knows fentanyl. It's a kind of a unique substance in the fact that it's so potent and it has a nice short half-life. So if you're going to have a surgery and you're going to be in the OR and it's a 40-minute case, it's the perfect drug.
Do you think that they're going to limit, if it really becomes like a nationwide thing, do you think that they're going to start limiting elective procedures and cosmetic procedures, things of that nature?
I don't think so. Because there are workarounds, as Kyle says. I mean, you can use morphine.
Okay.
But it's going to be less forgiving. Now, an old guy like me could say, you don't have fentanyl today. And I'd say, okay, I'll use morphine, and I know how to titrate that. And of course, the new anesthesiologists know how to titrate morphine. But if you err a little bit on the high side, now you might have a patient, that is discharged 2.5 hours later than they would have been discharged after their surgery. So it's just that it's just taking away one of the tools that we use every single day and using a tool that's not quite as good. I mean, we can still make the cabinet, but it's not going to be made with the ease that it's made with having fentanyl.
That makes sense.
It already takes so long at the doctor. I was just there last night, and because my dad had to go to the ER, and we were waiting for hours. It just, yeah.
Yeah. It's a mess now.
So, do you believe in safe supply? I know your content, so I know, but there's people asking, and how do you think that we could fix supply issues?
I think that what we're doing is not working. It's
Right.
an absolute disaster. But the fix is not black and white. I did a reel, you probably saw it, on, should we have safe injection sites and that type of thing. To old conservative guys like me, that's a shocking concept. But it's hard to argue that what we're doing now is working at all. So I think that people that have a substance abuse problem with say fentanyl, they're going to find it one way or another. And preferable to that would be to have a safe, pure, known product. Now, some limitations, of course, children can't get that and that type of thing. to have a safe place to use it. We know that in places like Canada and the Netherlands, that the transmission of needle-borne diseases has gone down, that this can be done safely and effectively. But, you know, what bothers me, I guess, is seeing New York and saying, hey, we got a vending machine, you know, you can get your Narcan here. Well, what they have in the Netherlands is a safe place to go, but there are rehab services right there. Can we get you into rehab? You know, this is what we have to offer. And it's never a matter of, oh, you don't have like $10,000? Oh,
Right.
you can't go in. There are no hurdles. So they've got that. They've got housing assistance. They've got job assistance to try to get people sort of integrated back into society and out of a life of misery. Now, they've done that in Portugal and had a lot of success until recently. And now even those sites are having trouble in terms of crime in the area, and they're really rethinking it. So I don't know what the answer is, but certainly what we're doing is not the answer.
That's a good way to say it.
Yeah. When it comes to all of that and the fact that they're just making pain patients not able to get prescriptions anymore, what do you think's going to happen with that? Because it's starting to get scary.
You know what? It is scary. And I think, you know, when it's scary for my wife, it's scary.
Right.
Because I know that physicians have sort of gone out of their way to say, we'll give you what you need. But when 2016 rolled around, there was her doc saying, all right, we got to get you down. And she was with every other patient in America. I think that, well, I think that the pain societies and the pain patients have spoken loudly after 2016, and they'll speak even louder if we get to a situation where we're saying, you know what, you're out of luck. But I understand that very much from my wife's experience and the way she sees life, that as a pain patient, you've got to do everything you can to kind of prepare. So my thought is, first of all, optimize your non-opioid treatment that you can. Secondly, have a good relationship with a pharmacist. You know, we don't go to CVS and we don't go to Walgreens. They don't have enough employees. The employees are overworked. They don't know who you are. We go to a pharmacy where there are only a couple of pharmacists. We know them. They know us. If there's a problem getting her Percocet, you know, I know they'll bend heaven and earth to get it. So we've never had a problem with that. She keeps a little stash, a little extra supply as a security blanket. And we did something that you know the viewers here may think is controversial, but we set out about 6 months ago to try to get her dose down. And I said, you know, you are clearly tolerant of this and habituated. And if we can, I think it would be good to get you down on a low dose where, let's say you have to have surgery, it's going to be easy to control your pain. And we said, let's take many months to do this. And we took many months, and she's done really well with it. And last Thursday night, she dislocated her hip. Had to go into the emergency room. They tried to put it back there, and they couldn't. She had to go to the OR to have it done and stuff. Wow. She got 4 milligrams of morphine in the emergency room. And I thought, oh boy, this isn't going to touch her. And
right.
It absolutely took her pain away. And I thought, thank God she was successful in tapering down to a smaller dose so that it wasn't a struggle. It wasn't an argument about, look, it hasn't helped her. You need to give her more. Well, we give her what we normally give. You know what I mean? So I think all of those things. Get a relationship with the pharmacist. Optimize your non-opioid therapy. Taper down if you can. And if you can't, I understand. It is what it is. Does that make sense?
Yeah, yeah. Did she ever have one of her doctors start talking to her about Belbuca or subs or anything like that? Because that is one thing they're doing to a lot of pain patients is switching them, trying to use the same fix that they're using for substance abuse
Yeah.
patients.
No, we've never had that conversation. It's never been broached. And to me, it's like, well, I'm not sure you can titrate the patient to their pain the way you can if you don't have an antagonist. So I've seen the conversations and the discussions, and I can see why people are really upset with this push.
Do you think that people that are struggling to get their pain meds, and especially with like next year, the pain meds are going to be cut down a little bit by the DEA? What are their options if they've tried all the things that you just said, the natural things, titrating? Do you think that they're going to have to be kind of forced to go on Suboxone, methadone to a clinic?
Well, I think Kratom is not a bad option. I didn't know about Kratom, so I read all about it and did a few reels on it. But it seems like, I mean, it acts on a mu receptor that if you can get, just the way morphine and fentanyl do, and if you can get a relatively clean product, that is an option.
How would somebody know if it was a good form of kratom? Like, what's a reliable? How would you know if you're getting like you wouldn't want to go get it at a gas station, right?
Exactly. Yeah, there's a I think it's called Kratom America,
Mhm.
or is that what it's called?
Yep.
Yeah, and that looks like a really good site. You
Okay.
know, no wild claims, and they've got a number of purveyors on it that they say, look, these are reliable. Yeah, it's not going to be adulterated, and it's going to be the appropriate potency. Um, so I think that would be a reasonable option. And if you said, hey, you know, my prescription ran out and it's Friday, and the pharmacy says, sorry, you know, it's coming across town, we'll get it Monday. That's why you have that little stash built up. And I think Kratom would be a reasonable alternative then as well.
Now, what if somebody's tried kratom and they still feel like, well, I've tried that and it didn't really help? Would the next direction be to get on some form of medicated assisted treatment? Because a lot of the people in the pain community are worried because they don't have that substance use disorder diagnosis. So technically, those clinics, how could they bill for it?
I just don't know. I mean, I would be leery. Um,
Right.
yeah, I mean, especially if I was getting an antagonist and I'm needing a large dose of an opioid.
Somebody here saying my pain management doctor tests for alkaloid and will not let me supplement with it.
Really?
It's because some states it's illegal, so they get really finicky about that. It's only illegal, or it's only legal in 32 states, something like that.
Yeah, I've seen somebody get arrested. Somebody I follow on TikTok, actually, a girl crossed the border from state to state and she got locked up for having it.
Yep.
Really?
Yep.
Yes. I'll send you the reel if I can find it, Doc.
So there are also small things with using kratom, especially if it's a pain management or a person that deals with pain and only uses the kratom for pain. They will probably have great results.
Yeah.
If you are a substance abuse issue person, anything like that, kratom is addictive, so that can be an issue there. And kratom, if you don't moderate how you take it and you start taking too much, it will destroy you on the inside. So that's just one of the things that I think it works great for pain patients, but it's a scary tightrope to walk whenever it comes to people that are dual diagnosis.
Can we discuss ketamine? Because I know that was one that you said could be very helpful.
My favorite drug.
Okay.
So ketamine is an anesthetic agent. It came out in I guess the 70s, maybe the late 60s. It has an effect of supporting your blood pressure. So we would induce, let's say you've been shot and you've lost a lot of blood. We got to put you to sleep for emergency operation. Your blood pressure's sort of in the tank. We've got to somehow support it while we give you a general anesthetic. Well, you get ketamine because that supports your blood pressure until we get your volume back up, and then we switch you to other agents. So it was used as a anesthetic agent for years and years, and it was used for its analgesic properties with anesthesia, and would be the agent of choice for something like a burn dressing change in children.
Yeah, that's hard.
Extremely painful. The downside of ketamine was its psychoactive effects. People would have disturbing dreams, maybe wake up and they still have it on board and they have some hallucinations, that type of thing. So when we gave it, we usually gave a benzodiazepine with it. Early on, we gave Valium, and then later, modern day, we use Versed. About 25 years ago, the psychiatrists stumbled onto the fact that ketamine could treat depression. And their literature, they would give it IM, 0.5 milligram per kilogram, a very small dose, six treatments over 2 weeks. And they found that about 60 to 70% of patients had their serious depression relieved.
Wow.
So it has become one of the 4 legs of the stool for treating major depression. Leg 1 is the oral medication, Paxil, Zoloft, Cymbalta, etc. Leg 2 is electroconvulsive therapy. Now, both of those have about a 60 to 70% effectiveness rate. Leg 3 is this TMS, this transcranial magnetic stimulation, non-invasive, but it takes 30 days and it's quite involved. That has 60 to 70% effectiveness, and ketamine, 60 to 70% effectiveness. Ketamine can be given nasally with an FDA-approved formulation, but it's a real hassle. You got to take it once or twice a week. You got to go to a clinic. It's horribly expensive.
That's what I was just about to get to, the price. I know people that have paid up to like 6-7 grand for ketamine infusions.
Yeah, if you can afford it, I think the best thing is the ketamine. Now, The best thing is oral medication. And you know what? My Zoloft does me just fine. Well, you don't need ketamine. But the patients that we saw in our ketamine clinic, they had all failed. And so if you can afford the infusions, you can usually get a series of them to begin with, and then once a month or so, you get a booster. My wife gets her booster every 3 weeks, but she takes it also for CRPS. And I realize that money is an issue.
Right.
And if you can't afford it, you can try to get it compounded from a pharmacy and then take it nasally. I don't think you get it quite as good a result. And you have the chance of, getting some, psychoactive effects that may be unpleasant, but at least it's affordable. The other thing with ketamine is it's also been shown to be effective in treating PTSD, compulsive disorder, and CRPS.
Can you explain what CRPS is? Because there's people in the comments that do not know what that is.
Okay, CRPS is the pain syndrome you don't want. It's chronic regional pain syndrome. It originally was called RSD, reflex sympathetic dystrophy. And it follows an injury, often a trivial injury, even something as trivial as drawing blood. Usually it's a bigger injury, like, I fractured my wrist or something. And it's a pain that develops after an injury that is out of proportion to what you would expect. That it goes through this sort of progression of your, let's just say it's your wrist, of it becoming hot and really tender to the touch, something we'll call allodynia. with a higher temperature. And then over time, over many months, it becomes then cold. So there's a hot phase and a cold phase. And it's also characterized, it's characterized by pain in a non-anatomic fashion. If I injure my ulnar nerve, well, my pain is going to be along the course of the ulnar nerve. But if I've got pain that's just spreading up my arm like this, well, there's no innervation that spreads up your arm like that. So that would be suggestive of CRPS. So CRPS untreated is an absolutely debilitating pain that often you can't. I can't have a shirt sleeve touch that part of my body.
I've actually been experiencing those symptoms, like where certain clothes, if a fan blows my way, the air bothers me,
Really?
Water bothers me when I take a shower, like the temperatures. I actually just texted a friend of mine saying that this week. It's literally, I feel like I'm crawling on my skin sometimes.
Have you had an injury of any kind?
I do have back issues.
Well, CRPS is one of the most hardest syndromes to treat. The treatment starts with aggressive physical therapy and using the limb, and then something we call mirror therapy, which involves it's the physical therapists do it. They use a mirror, and you get the good side working, and that's somehow in the brain makes you think that the bad side's working okay. And sympathetic nerve blocks early that anesthesiologists do. But when it gets established as long-standing CRPS, there's not a lot of treatment for it. People take the membrane stabilizing drugs like gabapentin and Lyrica, but we know all about the side effects and the problems with those. My wife is on gabapentin. And it just turns out that ketamine seems to help people with CRPS.
Wow.
Now, unfortunately, you have to give a bigger dose, and it's a little bit more of a to-do than with depression. But for patients with CRPS, they will do anything for relief. So my wife gets ketamine every 3 weeks for depression and for CRPS.
I was about to say a lot of the symptoms probably go alongside each other, depression with that, right?
Yeah, it's hard to have CRPS and not be depressed, frankly.
Okay. Makes sense.
Yeah.
I mean, pain causes a lot of psychological effects in people. And you know what I've experienced over my time with like chronic pain? They want like you got to go to a psychiatrist. You got to go to a therapist, a psychiatrist, but that's not treating the pain.
Yeah. No, what I need is I need to have my pain treated.
Right.
Yeah. Yeah. You see with so many things, cognitive behavioral therapy. Yep. That's what you need for this.
What about biofeedback? What do you think about biofeedback?
I think that whatever works for someone is worth doing. Some people maybe biofeedback, maybe some people acupuncture, maybe some people something else. I'm in favor of whatever works.
We did want to talk about a couple of things other than that. So we wanted to do nitazines and just get your opinion on what's happening with the kind of like craze of those now.
This is something that I read about from, I get these, medical notices, even though I'm not practicing. And it's about nitazines. You're going to be hearing about this. And I'm happy we got guys like GT on this. He's such a knowledgeable guy.
He is. I love him.
What a resource. So nitazines are this class of synthetic opioids. And synthetic, not made from the poppy. Poppy, you go get your morphine. Synthetic, that would be fentanyl and its analogs. So I guess it was in the 50s that these were discovered. And they work on a mu receptor, so they work the way morphine does. And they were never commercialized. So they were just sort of forgotten, this class of synthetic opioids. And if you look at the medical literature at PubMed, now PubMed is the medical repository, the medical library of all the medical articles that have ever been written. You punch in nitazene, there are less than 30. You punch in fentanyl, there's more than 38,000.
Wow.
So that's how unknown they are. They were known to some obscure researchers until somebody had the bright idea that they would add nitazenes to their illicit drugs. And the scary thing about nitazenes is they're not illicit. U.S. never passed any laws about them. They were never commercialized. They were just forgotten in a lab. And there's a bunch of nitazenes. On the street, I guess they're called iso or Tony, because one of them that was well known was isotonitazene. And they have been cropping up now, along with illicit fentanyl and amphetamines and anything else that they put in these pills. And I think because they aren't illegal, or if they make a version illegal, the chemical structure is very simple. So a chemist can modify it a little bit and say, I got a different kind of nitazene. It's not illegal. Just the way xylozine's not illegal. Right. They're cropping up now as a cause of death.
What about trank?
Let me just say last thing about nitazene. In Knox County, more than 10% of the overdose deaths have nitazene in their system. So you're going to hear about this. It's really scary. Xylazine is classified as an alpha-2 agonist. Now, alpha-2 agonists are basically blood pressure pills, and there's a well-known one called clonidine.
Right.
I used an alpha-2 agonist in my anesthetic practice called dexmedetomidine, and we used it for its tranquil properties. If you have an endotracheal tube in the ICU, I might put you on an etomidine infusion. You'd imagine when you breathe a little, water into your trachea, you're coughing like crazy. Now put a plastic tube down. Dexmedetomidine is an alpha-2 agonist like xylazine. And we use it to tranquil patients. Well, when it was developed, the FDA said, you know what, this drops your blood pressure too much and it makes you too sedated. So we're not going to approve it for human use, we'll approve it for animal use. Now, in the US, some states have some mild restrictions. Oh, you got to be a vet to buy it or something like that. But a lot of states, no restrictions, and there's no federal law against it. So if you want to buy trank, if you want to buy a xylazine, you can get on Google and you'll find scores of sites out of China and India. It was really popular in Puerto Rico for a couple of decades, and then about 15 years ago found its way up to the East Coast. And it's now very prevalent in the East Coast. In Philadelphia, 30% of the deaths, the overdose deaths, have xylazine on board. Of the illicit fentanyl that the FDA seized last year, 23% of it has xylazine in it. So xylazine combined with this illicit fentanyl makes you very zombie-like. And I don't use that term with any disrespect to these people, but it's a pretty good description for they're just gone. They don't know why these people get these terrible sores, but I think it's because, they lie for 6 hours without moving, the blood pressure's down, it affects the circulation, and now you got a big sore. And some of these people are so addicted to this that they'll end up getting an arm amputated and continue to use their xylazine. I think it's a great question, but as an anesthesiologist, I think once you get real sleepy, you're helpless.
You fall where you're at.
Yes. Yeah. So if when these people are found, you give them Narcan to the point that they're breathing. And that's sort of the end point. You don't keep pumping Narcan in because you might put them into withdrawal. They almost certainly have fentanyl on board, but there's no reversal agent for xylazine. And so a lot of these patients will end up in the ICU. They'll be intubated. blood pressure support in the ICU. And this is happening so much now that I think it was just last year, there's a term that's been coined, toxic brain injury, for drug overdose patients that have survived, but they have brain injury as a result. And very, very tragic, very devastating.
When a patient is hospitalized like that, do you think that the doctor should put them on like some sort of opiate so that they're not in withdrawal? Like how I've been hospitalized and then woke up after an overdose and I'm like, I'm out of here. I'm out. But if they would have kind of helped me, I wouldn't have ran.
What a great question. Yeah, I mean, it just makes total sense.
It does. And it's a shame because I think it could get people out of that vicious cycle of like, I have to hurry up and sign myself out of the hospital right now, AMA, because I'm in withdrawal, or having people bring drugs up to the hospital.
Yeah,
Have you ever experienced that?
No, I haven't, but I think it's a great point that you bring up. And I think nowadays there is such a bias against opiates.
Right.
And I wanted to, if I can, just talk about this opioid-free surgery for a second, because I know it's a hot topic for people. This grew out of something called ERAS, Enhanced Recovery After Surgery. How to get patients out of the hospital quickly. You know, if I'm giving you a large dose of an opiate postoperatively, it's going to slow your GI tract. And if you're not eating, I can't discharge you. If you've got, you know, too much nausea and vomiting, I can't discharge you. If I need to have an IV in to get your pain medicine, I can't discharge you. So that, along with the whatever contribution that prescribing gave to our opiate situation in America, there was this push for ERAS. Let's have an ERAS program, and every hospital has ERAS programs now. And it is combining all the non-narcotic ways that we have to take care of pain, whether it's an arm block, and then things that IV lidocaine.
What about Exparel, stuff like that? Exparel? It's okay. It's like a nerve block almost. It provides like 3 days of like nerve block. Like say you have an abdominal surgery.
Long-acting bupivacaine.
Yes.
I mean, and you know, and look, it makes sense. If I've got an inguinal hernia and you give me some local in the ilioinguinal nerve and along the incision that's going to take my pain away for 3 days, I'm all for it.
I've utilized Exparel for an abdominal surgery, and that helped me, especially because I'm in recovery. It gave me that extra 3 days of pain relief that I needed.
Well, I think ERAS makes a lot of sense. They're good programs because, I mean, who's not for, you know, minimizing all the narcotic that you need postoperatively? But it's become almost like a religion where I'm going to somehow convince myself that because of this program, you don't need an opioid. Well, maybe you don't need much of an opioid, but if you need it, you need it.
Right.
And so I think this ERAS has, you know, it's just come to live a life of its own. It's like a little Frankenstein monster. When it works, it's fantastic. But when you have it and a patient still has considerable pain, you have to give them what they need. And but the natural extension of this ERAS is these places saying, we do opioid-free surgery. Well, I'm not interested in going there. I'm interested
right. Don't sign me up for that one.
I mean, I'm interested in a place that says, you know what? We do all these techniques to minimize your need for an opiate post-op. And if you don't need it, fantastic. Then we're all going to celebrate. But if you do need it, we're going to give you what you need.
The number one problem, no one's getting anything, especially I've talked to countless people that went to like the dentist and had so much work done and can't get a single pill. Like, that's crazy.
It is absolutely crazy. You know, it's taking this, you know, skyrocketing overdose deaths in America and ascribing them all to, a 3-day supply of Percocet after your molars are extracted. I mean, that's not the problem.
The very last thing we want to get in at least is the Grateful Dead story. We have to know what happened.
Save that one for last, right?
Yeah, as I
Right.
said, I have a checkered past. So I kind of go off the rails. I went to college in New Orleans. I went off the rails during my college years. I was the youngest legal bartender on Bourbon Street at 19, and almost flunked out. And now I graduate. It's the height of the Vietnam War. I got lucky with a good draft number, and I do want to become a doctor. So I'm going to go and take my pre-med requirements, and I'm back part-time doing that. And there's this rock and roll emporium that opened up in New Orleans called the Warehouse. Now it's a very legendary place. The Allman Brothers played there once a month, and everybody who was big in the early 70s played there. If you give me the list of people from the Pink Floyd on down, they played at the Warehouse. Well,
Wow.
when it's being built, it was sort of not built, it was a warehouse basically, and they just sort of put a stage in and sound and all that kind of stuff. My friend Pete Gilbert and I got to know the guys that were putting it together, and we said, "Hey, we'd love to work here." And said, "Yeah, okay, good. Yeah, we'll hire you." So the weekend that it opened, they had Peter Green's Fleetwood Mac. This is back when Fleetwood Mac was a blues band, and his hippie band out of California called the Grateful Dead. And we worked Friday night. We just doormen, and then we worked Saturday night as well. And near the end of the show, one of the Warehouse people came to us and said, "Hey, you're invited to a party at the Royal Sonesta with the Grateful Dead." And we're going, holy cow. Now, at the time, you go to jail for years in New Orleans for marijuana. And the sound engineer for the Grateful Dead was this Owsley Stanley was his name. And he had just gotten out of federal prison for having 300,000 hits of LSD in San Francisco. And so I remember telling Pete, the town's too hot. I don't think we go to this party. He remembers that we were too stoned to go to the party.
Ugh.
One of the two. We didn't go to the party. The next day, Stanley is in the newspaper, handcuffed, being led away to the New Orleans Parish Jail with everybody else at the party. From that, the Grateful Dead wrote their hit "Truckin'," busted down in New Orleans, set up like
Wow. You were part of music history.
just about. So we passed up that party, and obviously my whole life would have been different if we'd gone.
Isn't that crazy to think about something so black and white like that? If I would have went left, I would have been screwed. If I went right, I did the good thing.
You love the butterfly effect. You talk about it a lot in the book.
Exactly.
Yeah.
I like this textbook that I'm in 5 editions of this, and people say, "What? You're one of the authors of Miller? These are the giants of anesthesia." And I'm thinking, yeah, I'm in there because I was the fellow with the famous guy. Yeah, it's crazy stuff like that happens that are, just unbelievably good for your life, and you just sit back and say, "Man, I'm just such a fortunate guy."
Do you enjoy your retirement? That is one thing. Like, what do you do in your retirement that you enjoy?
Yeah, in terms of enjoying retirement, as I said in the book, throughout my whole practice life, I had this sort of background anxiety that, and especially it was on call. It was like I was plugged into the electrical circuit, just fearful of what might happen. Even though I'd never had an emergency that I couldn't handle, it was just this unwanted companion, this background nervousness. And to my surprise, 2 things about the book. To my surprise, I've had physicians that read the book, surgeons that said, "David, that's exactly how I felt." And I thought I was the only doctor in America who felt that way. So there's lots of people, lots of physicians out there that they care about their patients so much that they're just fearful that they're going to make a mistake. And the other thing was when I say, one of the things I want people to get out of it is what a privilege it is to take care of patients. I've had so many physicians say, man, that connected with me so much. So the physicians that you run into, they may not show it, but certainly the people that I practiced with, we all felt the same way. What a privilege for people to to trust us with their care.
Right.
So retirement, yeah, I love not setting a clock and not worrying about what time it is. I don't get nervous on Sunday nights anymore, and I do all the things that I never had a chance to do.
And you have grandkids now, so it's like you could kind of redo things that you couldn't really necessarily do with your children, with your grandchildren.
Yes, yeah, yeah. I've got a 4-year-old, a 7-year-old in town,
Oh.
and they're just little bundles of testosterone. Uh, I golf, I read, I play the guitar, I just do things that you get to do now.
I love that.
I totally get that background anxiety thing. I, of course, don't have patients to care about, but just I have a business, I work a main job, I have this. It's like I'm always going, and yeah, something about it. It's weird.
Yeah, and I think that's a great point. You don't have to be a physician. It's I think that if you feel responsible and you care about what you're doing, it's that that responsibility you carry with you all the time.
It is absolutely crazy sometimes. But with that, I think we are good. I think we got all the questions we wanted. Thank you very much, Dr. Alfery, for coming on. This has been seriously a pleasure. Like it's been fun, especially after reading your book. It's been very interesting.